We talked about earlier that why we call diabetes a syndrome. The reason being that is there's a problem going on in 8 different organs. There are only 7 organs, but there are 2 portions of pancreas considered 2 different organs, alpha cell and beta cell. So there are 8 different organs defects is contributing towards what we call diabetes. It's just not pancreas. It's just not insulin. Insulin is not a problem. Insulin resistance is the problem that is developing in your body. And that insulin resistance comes from all this. All these 8 organs are responsible for creating this resistance. One of the biggest one we talked about is adipose lipotoxicity, which is adipose tissues. We talked about the excessive adipose tissues or fat cells in our body gets really malfunction, dysfunction, and becomes toxic type of chemicals that secrete in our physiological system that causes the insulin resistance. So that's very important organ contributing the hyperglycemia. Also, the liver is another vital organs that has one of the hormone come from pancreas called glucagon is very relevant. Glucagon makes a liver to secrete more carbs or more sugars in your body. And if that system is malfunction, you're also going to have a lot of sugar. Your guts are also very important in developing insulin resistance. Some of the medication works in your guts and some of the hormones in your guts. Kidney, it's really easy to understand. It's one of the glucose secretions, excretions, and reabsorption. And if a kidney's malfunction, can certainly create a high sugar in your body. And then you have the muscles. We talked about activity that can improve the sensitivity and reduce the resistance. So muscles are very, very important as well as in developing this resistance. As far as pancreas, they have alpha cell and beta cell. Alpha cell is where glucagon comes, beta cell where the insulin comes from. And then obviously appetite and various other hormones that goes into the brain can also develop insulin resistance. So it is the disease of multiple organs in our body. Now, this handout's not quite clear, but what I'm trying to, it's not very important either. So when you say controlling IRS, we're controlling this, the problem of insulin resistance syndromes. We're primarily just controlling the sugar. This is not really important topic for me. Although when you go to doctors, all they talk about is this, medications. They look at your numbers, it's going up, let's add another medicine or increase the dosage. Okay, so this is all we had been doing as a physicians, which is, we are the part of the problem. The couple of things that I would like to mention on this topic, which I'll go a little later. But this is basically, this handout talks about, one thing that I want to get across is that there are different class of medications here. And this different class of medications, what organ they're addressing. Okay, so this first one, top one, is metformin. Also, I cannot use the word metformin and all other legal stuff there. But anyhow, this first is classed as metformin. It works on the liver. It basically suppresses the glucose dumping in your body in the liver. Liver has a very high storage of sugar called glycogen, and the metformin suppresses that, so you have less sugar in your body. It doesn't address the insulin resistance. It just reduces the sugar. Even the metformin is considered one of the best medications in diabetes. Everybody takes it, 95%, unless if you have kidney problems. Almost every single diabetic patient takes metformin, which is also not the great medicine. Obviously, if you're taking it, continue taking it before a doctor tells you. The second one is sulfonylurea. That's glyburide, glipizide, glimepiride, those kind of medicines. That's the worst medication you can ever take. And we like to remove that medications. In the last 3 years, I probably removed this medications almost 90% of my patients and try to replace in something else. The problem with the way this medication works, it works on pancreas. What it does is, it doesn't treat the insulin resistance. It squeezes your pancreas to tell the pancreas to secrete more insulin. Okay? So over time, you lose your own insulin storage and resource. So that's what glyburide does, or glimepiride, or all of them are saying. So that medicine we have been prescribing for the last 30, 40 years, and it's very, and it's very cheap medicine. That's why if people have problems, financial restrictions, often they end up being on those medications. That's a double jeopardy for them. They have less access and they get the bad medications. The third one, it's very good medication, but the problem with this one is, I don't know if you've heard of Actos and Evendia and those kind of medicines. I've never prescribed these two medicines in my life. But this is very good medicine because it works on insulin directly. It works on insulin resistance. The problem with these medications were they had horrible side effects, such as heart failures and bladder problems and all kinds of stuff. So there's some of this medicine that came in the market, they banned the market, they came back. It's just on and off stuff going on with that. So because of a very poor side effect profile, I don't prescribe that medication. But it does address the problem, unfortunately. The other one is DPP-4. This one is our Onglyza or, gosh, I'm having a, what is this medicines, DPP-4 inhibitors are, can diabetic educator help me? Yeah. Januvia, yes. So we have Januvia, Onglyza, Tradjenta. Those are the medications, are DPP-4s. They are a good, relatively good medication that look at 1, 2, 3, 4. They addresses 4 different organs. The problem is not really effective, but it's a good medicine, reasonable medicine to be on. And then you have a SGLT2 inhibitors. These medications they work on the kidney. Essentially what it does is it dumps more sugar in your urine. That's how it reduces your sugar. Again, it's not addressing the insulin resistance, but it does, one other good thing it does help to lose weight somewhat, 5, 10, maybe 15 pounds. So in an indirect way, it can be helpful. A little more than just other average diabetic medications. So this medication are Farxiga, Invokana, Jardiance, those kind of medicines. And so they're reasonable medications to be on. Then you have a GLP-1. This is essentially, and many endocrinologists like this medication as well. The only problem with these medicines, they are injectable. The good thing about it is that they are some of them are weekly injectables, such as Bydureon and Trulicity. And then you have the daily medicines like Victoza or Byetta. And then you have, there's a weight loss medicines also is based on this mechanism, Saxenda, that's the name. So those are the 4 medications. They work. This is essentially the best medications that every diabetic can take. Most of the experts agrees on that. So it works on the pancreas, it works on the liver, it works on the guts, different alpha cells. It works on the, primarily it works on the guts and the hormones, and it can also suppress some appetite through the working on the brain. But you can look at it, every medicine is 1, 2, 3, 4, 1. This one works on it addresses 5 different problems. That's why essentially it's one of the best medicine. Yes? So if you were taking an injectable one, would you still take the 2 top ones with it? Depending on how bad diabetes or uncontrolled is. So if you need them, yes, you have to do that. So the good thing about this medicine and the last 2 medicine we talked about work on kidney, that the Farxiga, Invokana, and Jardiance, and then you have Bydureon and Trulicity, both type of medications. They do facilitate weight loss, so I like those medicines for another reason. But they do address some of the maximum amount of organs, the maximum number of problems that they address, and that's why it's my personal favorite medicine. Yes?
On television, you see a lot of commercials now about Invokana.
Right.
An attorney saying, let us know if you're taking it, and you're saying it has, side effects. Well, what are your thoughts on that?
I personally think that there was, I don't know how long ago, but a few months ago, there was some research was done regarding Invokana increasing risk of amputation, I suppose. it's really poorly studied. I looked at the research in various parameters, and I don't really buy that. In fact, excuse me. In fact, diabetic in general increases risk of amputations because of the unhealing infections and the extremities and toes and things like that. Again, that's my personal opinion. I cannot give you 100% guarantee that, but yes, there's some research that was recently done, and according to me, it's not a substantial research that would convince me. Not that I get any kickback or anything like that from Invocanon, but I usually, personally, I like the class. I prescribed all three medications. I don't have any personal favorite of Farxiga, Invocanon, and Jardiance. And this is ethical and moral. I have to mention all three at the same time. There are a lot of things in the media that you come up about both of these medications. There are a lot of things been stated online in various places. I have not heard any. I have not come across any substantial harm to diabetic patients. In general, we talked about. Again, I told you this slide is the least relevant for me. All the other stuff we talk about is more relevant. And this does not treat the diabetes. So, essentially, if you ask me, I don't like medications. But if I had to pick out of 6 or 7 class, those are the two I'll pick. Metformin is very well studied over and over, and very safe medications. Has been used for such a long time, and so I don't have any problem with metformin as well. So you can be on all of those medications. What the bottom line is that they're not addressing the insulin resistance. That is, and that's how our medicine is. Almost every single disease, we just do this: control, control, and control. We often never talk about treating, and so that's the larger problem across the entire healthcare system. So anyway, we don't want to spend too much time on this. The last one is insulin. It's probably the worst thing you can take. But I know diabetic educators mention that taking insulin, and now if I say it's the worst medicine, they're not even more afraid of. But that's the point. Is not here that if you have a heart attack, you definitely go to ER. You don't come to me or you don't ask me about what I should eat. So if you have significant out of control diabetes, and if you have to take insulin, you have to take insulin to save your life from immediate danger. What I'm saying is that once you get on insulin and nothing else works, you are very at the end stage of diabetes. But you are difficult to treat with other medications, but you're never difficult to treat with food. Diabetes can be treated with food at any stage. With medication, not quite true. So that's the point I want to. So I don't want you to be afraid of insulin. If you have to take it to save your life, you definitely take it. But out of all the other medicines we talked about, insulin and the other glyburide, glimepiride, those medicines are probably the worst out of all the medicines that I talked about. All right, this is everybody knows about this because this has been very heavily emphasized in practicing and treating diabetes. So there's no surprise there. Hemoglobin A1C, I'm sure every diabetic must know this term. Hemoglobin A1C essentially measures the average blood sugar of over the last 3 months. The reason is 3 months is the average life expectancy of blood cells are somewhere around 90 to 120 days. And so that's why after 3 months is not quite, every 3 months you need to redo this test. Unless it's well controlled, you can do it 6 months or 1 year, depending on how well they're controlled. Obviously, the ideal is under 5.7. Pre-diabetics, when you are pre-diabetic, means that you already have insulin resistance syndromes. Our sugar are just not high enough to be treated. So you already have a disease. Okay, so you need to start work on at this stage. If you are at this stage, you're lucky. You need to work on to reverse that to go here. Yes.
Here's a question I never get the proper answer from my doctor. If a person is we'll use the pre-diabetic, and I'll just say 5.9, can that person, with changes to their lifestyle, and that, bring themselves back to below 5.7, or once you're there, is that it?
No, absolutely. You can reverse it. Yes, there's no doubt about it.
Could you repeat that question?
Because the question is that once you get to this number of pre-diabetics, let's say 5.9, are you stuck with it, or you can actually go in the reverse direction? Absolutely, you can. There's no doubt. If you're carrying extra 50 pounds, you lose those 50 pounds. You might just go down to 4.9 or maybe 5. And we see that all the time, not just pre-diabetics, even diabetics. I've seen diabetics, they are taking 60 units of insulin, and I would not take the credit, but patient worked really hard to lose weight, and they got out of the insulin. So, so it's definitely possible. If you're diabetic, you can go into pre-diabetic. So definitely if you're pre-diabetic, you can reverse it. You can definitely prolong the worsening of diabetes for sure. There's no doubt in that. So other numbers, if you have 8 to 10 hour fasting, ideal under 100. For diabetics, if it's more than 126, we call them, or 125, 7, whatever that number is. And then this is 1 hour after. This is more for like diabetics. Normal will be even lower. But 1 hour postprandial essentially means after meal. 1 hour after meal should be under 180. 2 hours 155, 3 hours 140. So every hour just kind of should go down. And then usually before meal, your sugar should be 80 to 130. This is if it's well-controlled diabetics. That's what we're looking at, those numbers. And your goal should be reaching that. So if you have 6.5 and up, you're diabetic for A1C. And once you are diabetic, we are instructed to try to bring the patient under 7. That's the usual goal, to keep it under 7. If you are elderly or somebody's 80 plus, we tend to have a little bit of leniency, try to keep it 7.5 or 8 as a goal. Because some of the research showed in elderly population is the lowering sugar too much is much higher risk than leaving them a higher sugar. So, so we get a little more higher value for the elderly population. So, but if average age populations, they should try to aim under 7. And if you're really ambitious, you want to wean yourself off the medication and get down to under 5.7. That's possible. Depending on what stage you're working on, there are times I've seen people lost 50 pounds and still were not able to wean off all your medications. They still have diabetes. Again, it all depends on how much our pancreas got depleted from insulin, how bad your insulin resistance is. So there are all a number of factors how the aging of specific factors plays a role that your ability to reverse the disease. Those are the numbers. Now, this is other ways, especially early on diabetics, even not even early on, any time that just diabetics, it's very relevant to get the knowledge instead of instead of reading a book or asking a physician. This is another way of figuring out what food is increasing your sugar, what food is doing to your body. And that's where this term comes, a continuous glucose monitoring device, which sometimes you carry it for about 3 to 6 days, and it checks the sugar every 5 minutes. Again, if you're one of the, I have a few patients that they check sugar, it's high, so they don't eat for 6 hours. They check sugar if it's low, they eat a lot of sugar. So if you're one of those persons who checks 8 to 10 times sugar, this might drive you crazy. But this is very important more for introspection, for your own education. You can have a food log, and if you have a continuous glucose monitoring side by side, and you can get an idea, I ate this kind of food and raised my sugar. I ate this kind of food and my sugar was this. So continuous glucose monitoring can be very essential to more introspection about the food and sugar. Versus the finger stick, which you do maybe only once in the morning, but you have no idea what your sugar is all day long. So it's because we hear it all the time, your fasting sugars are good, but your A1C is 8. The problem is that your sugar after meal is not good. That's the problem. And the only way you know is if you measure it. Okay, so this is, I think, is an essential element in diabetics to have a continuous glucose monitoring. I don't know if your physicians have that. I don't. My clinic does not have it, but I'm really kind of lobbying it to have this the device for our clinic so that our patient can benefit it. The education that you get from your own, on your own, through your own experience, that education lasts much longer versus physicians telling you 20 times, right? So very important concept. So I always get questions asked how many calories I can eat as a diabetics. Again, if you needed weight loss, 1,200 calorie is what we need to get to. If you are in almost normal weight or overweight range, maybe 10, 15 pounds overweight, then you can go on to 1,600 to 1,800 calorie diet. Usually small meals is not the size or the volume of the meals, but how many calories it contains. That's how you determine small meals. And usually if you have less than 250, that's small meals. And less than 450 calories is a large meal. Average calories in large meal in average American diet, probably about 1,000 calories or more. And small meals, I mean, one nutritional bar is probably 250 calories. So it's very, very easy to get those calories. As far as people tend to ask about what would be my total carbs per day, if you are on a weight loss and very, very low carb diet, 50 grams a day, which is very, very difficult to get. Very, very difficult to get. But if you are really on a mission of weight loss, then 50 grams a day will do it. 50 grams a day with the 1,200 calorie together will do it. At the same time, if you are just the normal weight, you're not really looking for weight loss, then 100 to 150 grams of carb a day, I think is reasonable, even as a diabetics. And obviously, if you want to get most of the protein and fat, try to get it from more plant-based whole food. So that's sort of quick slides on calories. So this slide is more specifically for diabetics, very little about nutrition, the complications and things like that. I'm sure every doctors do not spare you from this education, so I'm pretty sure most of you know about this. Just go very briefly and quickly. These are the common organs that diabetes damages. The insulin resistance eventually damages your body. Eye, probably top 3 cause. Again, I'm not really good at those statistics and numbers, but I would say probably about top 3 or maybe top 5 causes for blindness in the nation is diabetes. Same thing with a kidney failure, probably top 3 causes of a kidney failure or dialysis in our country. Obviously heart disease, diabetes is the major one, and amputations, obviously chronic non-healing infections of the toes and foot can lead to the amputation for preventing further osteomyelitis or infection of the bone and further damaging the life. So amputation sometimes becomes the only option. Infections, you are increased risk at hepatitis B, pneumonia, flu, all kinds of infections. So definitely I'll encourage to follow the guidelines of all the immunizations required for diabetics. So if you're under 60, make sure you get hepatitis B vaccine. Shingles after 60, pneumonia, the day you diagnose diabetics, you need to get first pneumonia vaccine, and the flu vaccines every year for everybody. For diabetes, even more relevant. So the infections, you do have a impair healing or prolonged healing for any infection, and that's why you don't want to get it to begin with. So that's why immunization becomes very relevant. Vitamin B12 and vitamin D is often found deficient in diabetics, especially people who are on metformin tend to have deficiency in B12. So almost all diabetics at risk get vitamin B12 deficiency. And obviously, the other two other diseases, cholesterol and high blood pressure, if your diabetes is well controlled, you definitely want to control high blood pressure and cholesterol. Those three diseases definitely need to be in absolute control along with diabetes, even more relevant to control those diseases if you're diabetic. There are separate guidelines for blood pressures and stuff and cholesterols. In reality, if you are diabetics, according to the guidelines, cholesterol guidelines, which is ATP guidelines that use, the latest guidelines for the cholesterol is we no longer chase the specific number of good and bad cholesterol. If you're diabetic, we automatically put you on very high dose statin medications of cholesterol lowering. I'm not a big fan of that guideline, but that's what the guideline shows based on the evidence they have. And high blood pressures, the guidelines keep shifting from 130 to 140 or 80 to 90. But ideally, you want to keep your blood pressure under 140 over 90. So that's very essential overall, controlling and preventing the complications of diabetes. Very relevant as we talk about. We talked about this. You have right to demand better treatment. And we talked about what are the better treatments. The number one treatment is food. There's no questions and doubt about it. If you're demanding medicine, before you demand medicine, you want to demand a better food. I put down here 80%. Obviously, I have a bias. I'm personally exclusive plant-based diet. I try my best. But 80% is what I expect from, or I recommend my patients to get. At least 80% of your daily caloric intake come from whole food, plant-based. That's the idea. The other things here, the second one we talked about, Bydureon, Trulicity, Victoza, Byetta, those medications. I put that as a second best medicine. Then I put the third one, those kidney, the dumping sugar in the kidney for Farxiga and Nucana Jardiance. And then obviously metformin. And then you also want to familiarize some of the weight loss medications can also help you controlling your diabetes. So weight loss is very important so demanding these treatments from your doctors, it's a very fair game. Okay. As far as weight loss medications, Saxenda is very similar to this number 2, Bydureon. So it's really easy to understand that not only that helps the weight loss, but also helps diabetes. The second one, Contrave, which is a combination of naltrexone and bupropion, which also has shown improving the hemoglobin A1C. So which is also, but it's primarily a weight loss medications. The problem is twice a day. Qsymia does indirectly by losing weight, it does help diabetes. Same thing with Belwig. So there are 4 FDA-approved safe weight loss medications that has been studied for on large number of population for a long period of time.